Okay, hello everybody. This is Michel Akkad. With me is my co-host Anish Koka, and we're delighted to have with you a special guest today, Swapnil Hiremath, who's assistant professor of medicine at the University of Ottawa in Ontario, Canada. And Dr. Hiremath is a nephrologist and a clinical epidemiologist who obtained his MD from the Seth GS Medical College in Mumbai, India, trained there in internal medicine and nephrology, completed a renal fellowship at the University of Ottawa, and obtained a master's in public health from Harvard University. He has more than 100 publications under his name in peer-reviewed journals. He is very active in traditional ways as a clinical investigator at the Ottawa Hospital Research Institute and as director of the Canadian Society of Nephrology. But one of his most important claim to fame, however, is as co-founder of NephJC, a highly successful Twitter-based journal club, now in its fourth or fifth year of operation. And Dr. Hiremath is highly respected among colleagues for his insights and for the kind and generous way in which he shares his wisdom online and in person. Swap, welcome to the show.
Thanks for having me. And thanks for the kind introduction. NephJC, in fact, just had its 100th chat session. It's been 4 years. And when we started, we didn't know that it would be so successful. But we have been doing continuously a chat twice a month for the last 4 years and 3 months. And the 100th chat was on renal denervation, so back to hypertension.
It's really amazing. Let's talk about NephJC for just a couple of minutes, because it's remarkable that spontaneously you guys got together. You probably met on Twitter or didn't know of one another, and have managed to organize a website that has a lot of information that helps people who are afraid of Twitter or concerned about social media. You sort of hold their hands into the process. You prepare the journal clubs with you have the articles of studies on the website and key points to discuss and so forth. I think it's really remarkable. It's wonderful to see, and I congratulate you for that.
Thanks. It is true that Joel Toff, kidney boy, who co-founded NephJC with me, it was a Twitter conversation where we were talking about an article, and I suggested, why don't we do a journal club on Twitter? And I think Joel told me, why don't you do it? He was hoping I would go away and not bring it up, but we did, and we were not the first ones, but I think a lot of the ideas behind NephJC, the website, having a mailing letter, they're all Joel's idea. He has a brilliant creative mind about how to do education in this kind of media. But it's been, the community has been very supportive. We have got many other people involved now. Our group is like 30 people now. So it's been a fun journey.
My bet is that the NephJC has attracted, I'm sure, a huge amount of nephrologists to Twitter. So even if they're not active, I'm sure that a large number of folks are engaged in Twitter. Because initially when I got on Twitter, I don't know how many years ago, I didn't understand the value of it because the community is not really there. So just like when my parents came to India in the and participated in whatever community temple organizing, and that was the forum for everyone coming together. You I think you and Joel have essentially set up the structure which creates value, which then draws all these people in. So really, really amazing job.
Yeah, it's sort of like our monthly rounds, right? It's like our meeting place for nephrologists.
Yeah.
You pop in, you say hello, and
Though Swap, I think you really have to dumb it down a little bit for cardiologists. I mean, you guys are so cerebral. Can you need like a baby journal club for cardiologists to join in?
Not at all. In fact, when we did the first renal denervation chat way back in May of 2014, John Mandrola joined us then, and we did a Google Hangout. We stopped doing that because it's a lot of work. I don't know how you guys managed to do this, but it's so much work to get few people around and do it. So we tried doing that and we gave up. Yeah. But John Mandrola and Joel and I did a Google Hangout on Simplicity 3.
Yeah, very good.
Cardiologists join us,
right? Which I think we'll talk about renal denervation on this episode here on this show. We're mostly, I think, going to talk about blood pressure guidelines. But before we do that, actually, I wanted to get the impression. Both of you guys. I don't know if you saw that paper that just came out. It was tweeted by Eric Topol about spending at the end of life Did you see that paper in Science Magazine by Amy Finkelstein? It just came out, showing using AI and machine learning algorithm. They discovered that, the saying that we're spending, 25%, or I don't know how much, 25% of Medicare money is being spent in the last year of life, and therefore it's completely wasted. And lo and behold, they discovered that spending money at the end of life is not necessarily wasted, because you don't know when the end of life is. Most of the time when you spend money, you're trying to save people's lives, and you don't always succeed. And what did you think of that? Did you hear about it, or?
I saw Eric Topol's tweet, and I think Lisa Rosenbaum also made a comment saying that, in hindsight, it's very easy to say that, oh, all this money was wasted. But in foresight, it's very hard to say. I agree with the results seem plausible to me. They seem biologically plausible to me.
The what amused me, I didn't read the paper in detail, but I saw the beginning of it. I scanned through it, and they so they make allusion to this this notion that's very common, that we're wasting too much money. And then, as example of people who hold to that notion, they make a reference to a certain New Yorker article from a few years ago, written by Dr. Gawande, and so I thought it was funny. I don't, that, yeah.
There should be a whole. I mean, we should definitely dive into this separately. But I think the most significant thing from the paper is that the idea that the prediction of death is so bad. I mean, you had these very highly sophisticated folks that they had all these variables. They were pumping it into, I think it's some AI machine learning, more stuff that's above my head. And despite that, they were completely and utterly unsuccessful at figuring out who was and who was not going to die. And that's so important, because you have this vast amount of data from a bunch of places that's coming in that says, value-based payment based on risk-adjusted this. And I mean, the whole concept of risk adjusting really needs, and making conclusions based on all this risk-adjusted data and risk is really fraught with a significant amount of problems, I think, given this kind of stuff.
Right.
So that was the big take home for me.
Right. And it turns out, so from the paper, the conclusion was that only 5% of money could, arguably be considered wasted because patients, would have a high probability of dying anyway. Right. But even then, a high probability of dying, does that mean that you're wasting the money necessarily? I mean, what percentage do they want? Anyway, so I'm glad they did the work to sort of appease the the people who have been making this silly argument in my mind for many years. And perhaps Dr. Gawande will learn the lesson here as he plans for the future of healthcare in America. All right. But today we're going to talk about guidelines. And Swap, just a few days ago, I don't know if it was in the context of a NFJC Twitter chat or not, but you were reviewing the blood pressure guidelines, and you showed a slide, and you titled the slide "A Buffet of Blood Pressure Guidelines," which I thought was a great term here, a buffet of guidelines. So, open-ended question to you: why do we have a buffet of guidelines on the definition of hypertension?
I'm
putting you on the spot here. I know you.
No, that's okay. I was the one who put my foot into it by saying it's a buffet or a smorgasbord or whatever you want to call it. But it just shows you that even if all the groups, the European Society, the American Heart Association, Hypertension Canada, the Australians, those are the ones that I quoted. All of them are looking at the same studies, and they are coming to slightly different conclusions based on the way that they are reviewing the studies. One could argue, as a hardcore evidence-based guy, I feel like a lamb walking into a cave of
Be careful, yes.
Yeah, but still, the Australians and the Canadians are pretty close because they are sort of saying, hey, Sprint, we believe that, we should follow the hard evidence. Sprint is 120. They found these results. So in these kind of patients, go for 120. The American Heart Association guidelines are harder to understand, to be honest, but you could argue they are more pragmatic. They are saying, let's look at the achieved blood pressure in sprint rather than what you're intending to go for. I think the other aspect is in Canada, we have those automated blood pressures, the same as what was used in sprint. Roughly half the family practice practitioners have the automated blood pressure machine. So it's applicable. The sprint data is perhaps applicable to our family practice. In US, it's not true. I think less than 10%, maybe less than 5% have those machines. So is the data really useful? How can you, is it applicable to them? And the last part is in Canada, we don't have any pay for performance measures. We don't have any, I don't know, MIPS and MAX and whatever those terminology that you guys have. So we have nothing like that. So even if the guideline says 120 and the family doctor does not achieve 120, that's okay. No one is going to come after them. That was a huge concern when we discussed that. We had brought Brent Egan to discuss what AHA guidelines might say before the AHA guidelines came out. And he said this is the biggest issue, because if you want to go for 120, you will actually have to aim for 110 to make sure all your patients are less than 120. And if that is the place that the doctors are going to go in US, that will definitely not be good. So it comes back to, should guidelines just be guidelines, or should they be used as performance measures? And if they're used as guidelines for the guidance, I'm happy with that. But when people take the next step of making them into performance measures, that just becomes very tricky.
So Swap, how do you pick from this buffet? What is the tastiest option that you would choose?
So that's why I called it a buffet, because you can choose whichever one you want. It's not easy. It all depends on your settings. So even though Hypertension Canada says 120 for patients who are at high cardiovascular risk, I'm finding it very hard to go and achieve 120. And you could argue that, it's not the achieved blood pressure. It's that you're intending to go aim for 120 is what matters. You keep intensifying therapy as long as the patient tolerates it. And I think that's the hard part, is that you intend to go for 120 and you don't look at what your patient achieves. I like that part specifically.
So do you, I mean, as you know, sprint, these guidelines attempt to sum a large number of trials over a variety of different patients. So I guess you're saying, you're giving single numbers in terms of, okay, this is where I'm going to try to go. But I guess in your practice, diabetics you let ride higher because of a cord? Do you, for sprint, you follow sprint to say, okay, if you have CV risk factor, then only I try to go to 120 over 80. If you're very old, based on, if you're 75, do you relax your guidelines a little bit? Is that, what is your practice? How do you choose a different guideline for each patient, or how should you do it?
So 75, because you raised the 75, I'll take that one first. That's a misconception. Okay. So Hivet brought it down to 150, right? So if you go back, if you look at my first post on FGC on the renal denervation stuff, people used to argue whether blood pressure should be treated at all, right? Even so in 1856 or something, Ludwig Probe said, hey, maybe blood pressure is for a reason. There are less nephrons, so you need higher pressure and so on. So that argument continued until Hivet came, and Shep and then Hivet, which showed that, if you go down to 150 in the very elderly, more than 80 years of age, it's better than letting them be at 160. So they showed that, hey, 150, lower mortality, lower stroke rates. That doesn't mean that 150 is the right target. Sprint went to 120 in those who were more than 75. And those patients achieved a better all-cause mortality. That is a JAMA paper by Williamson. So more than 75, I would say you should still be aggressive. The problem is that it's the patients who were enrolled in sprint. They are kind of the healthier 75-year-olds, right? They are not, if you were in a nursing home, you are out. If you were in a wheelchair, you were out. If you had a standing blood pressure less than 110, you were out. If you were at high risk of falls, you were out. Do you check standing blood pressures? Most family doctors don't check standing blood pressures. Even our clinic in nephrology, we don't check standing blood pressures. In our hypertension clinic, we do check standing blood pressures. So, it's hard to apply that age greater than 75. So people start using all these heuristics. Hey, this patient looks frail, they look like they might fall, so let's back off. The ones who are more than 75 are the ones who are at highest risk of cardiovascular events. So you want to be aggressive in those patients, I'll argue.
And Swap, if I recall, in Sprint, the people who were older than 75 did better in terms of hard outcomes, but didn't they have a higher rate of syncope and faints?
Yes, they did have a higher risk of all the adverse events. So the intensive overall had a high risk of intensive events. But one could argue that all-cause mortality is the adverse event that's most important, isn't it?
No, I'm not disputing that. So I'm not, but I just wanted to remind myself. Yeah.
So just to follow up the misconception of age. So where do these wacky family practice physicians get? They've seemed to like the JNC8 committee. What the JNC8 committee says. So where did the JNC8 committee come up with their this idea that
So that is so interesting, that whole aspect, isn't it?
Yeah.
You called them wacky. I did not, but I've been very critical of the ACP AAFP guidelines, right? They are like 150 and 160. Even after Sprint came out and even after AHA came out, they're saying no. But if you step back, there was JNC7 and then there was JNC8, but JNC8 actually, the NIH decided, hey, let's get rid of JNC. We cannot do this. We are not going to do guidelines anymore. But the work group that comprised JNC8 had done a lot of work. So they said, we'll still put out a guideline. So if you see the JAMA paper, which is JNC8, they don't say it's a JNC8 report.
Right.
They say it's a report from the committee that was JNC8. So they're not really official guidelines. And this was a guideline where Jackson Wright and a couple of other people, they wrote a minority report, which came out in Annals of Internal Medicine saying, hey, this is not, we disagree with the rest of the committee. And their point was, the minority report's point was that Sprint is happening. Why are you pushing for this guideline when Sprint is coming out? So the definite sense is that this is the less is more kind of philosophy, which is, hey, we like this, so let's go for it.
But was that less is more philosophy? Was that based on anything? What was that based on? What data was that based on to suggest that the older you are, you should not? They didn't know they didn't obviously know.
So it's an absence of evidence. It's not an evidence that lower blood pressure is harmful. It was just because we didn't have evidence that lower blood pressure is useful. And if you see the ACP, AAFP guidelines, they did a systematic review. It was a proper, they follow a process. So they did a systematic review. But if you read the systematic review, they said the intensive arm is less than 140. So they grouped everything in less than 140, right? And so the whole premise was that, hey, we are not even going to look at more intensive blood pressure lowering. So this is where, you can say it's a systematic review. You can say, it was, they looked at the whole literature. But if you make your methods such that you will not find the right answer, you can definitely do that. I think it was a flawed systematic review.
So I think you're saying there's a systematic bias on the part of the family practice organizations here to do this. Meaning it's just bias. It's not based on any real evidence. And certainly when the Sprint data comes out, that kind of should tell you that, hey, lower is better even in the elderly.
So even I was not completely bought with 120 until Sprint came out. So. I to be honest, I was taken aback when Sprint came out because the bias was less is more and, let's back off and JNC8 and so on and so forth. But if you actually step back and go and look at the evidence in the totality, so even if you look at ACCORD, there is a clear signal. It's just that it wasn't statistically significant, but the point estimates are all in benefit, even if you look at ACCORD. So Vlado Perkovic, who wrote the editorial accompanying Sprint, he compared the two, ACCORD and Sprint, and they overlap really. There's no interaction between those two groups. If you look at ACCORD and Sprint, and if you look, there is a very nice systematic review by Etihad that came out just after Sprint in Lancet. So they looked at all trials, and they still show that if you look at the other trials, the previous trials were underpowered to show a benefit. Sprint was the first, it was 9,000 patients. It was larger than in many other trials, unless you go back to ALPAT. Which showed that there was a benefit. So it's not that the previous trials showed that lower blood pressure was worse. It's just that they were underpowered to show a benefit. And then Sprint came along. But people are just closing their eyes and finding some problems with sprint.
Well, I have. Let me step back a little bit, Swap, or maybe push back on the whole idea that we should have guidelines in the first place. At least guidelines with numbers, with cutoff numbers. That's my biggest problem. I mean, right now, if I have a patient whose blood pressure is 138 and he hears in the New York Times that this is hypertension, and he comes to me, he says, "Oh, I heard that. I don't want to start medications." Should I tell him to just move to Canada and then he'd be cured? So, I mean, these numbers are making everything hinge on numbers is the problem to begin with. And even if you say it's based on sprints that we have these numbers of 120 and whatnot, it really can't be the case. I mean, there's nothing physiologic about 120 or 130 or 140. I'm sure that's the case. The risk curves are always very smooth and whatnot, and then you may have an increased number of complications below a certain level or above a certain level and so forth, but it's always smooth. There's no inflection point. The studies are designed to begin with by pre-specifying what the cutoff numbers are going to be. They're going to get, the study will say, let's aim for a target of 120 and say, let's see what happens. But that doesn't say that below 120 is advisable for everybody and so forth. So what's wrong with just having a clinical guidelines that say, as a general rule, lower is better. Okay? Individualized care, because there can be complications at both ends. End of end of guideline, right? Is that a problem? Do you think people will just will have an epidemic of strokes because people will be under treating and so forth?
So lower is better, meaning how low, right? Isn't that necessary? People like to have a goal to achieve. If 140, is that low enough? Is 130 low enough? Or should you keep targeting until they have side effects and they're passing out?
Yeah, but I think you can make a stronger case than 140. You can say we have epidemiologic mm-hmm. evidence, or even clinical trial evidence. We have mm-hmm. the sprint evidence that says that even down to 120, it seems to be better. Okay, mm-hmm. So I'm not disputing the value of the clinical trials, mm-hmm. But I'm disputing the concept that based on those clinical trials, then we have to turn around and issue guidelines that have cutoff numbers like this, because there's an inference here that to me is incorrect. I think lower is better in general, and you should push and you individualize, because if you have somebody you can advise to take the blood pressure standing. I think that's a very good advice. I'm going to start doing this in my practice, and so forth. But having these disputes, these constant disputes, and it's been constant for decades. I mean, JNCA didn't come out. There was a hiatus of 10 years because people were disputing. And each time you come up with guidelines, then you label people. You have millions of people who all of a sudden become labeled as hypertensive or whatnot, and I think nobody puts that kind of harm into the equation, and the whole brouhaha and the waste and all that stuff that goes with it, and it makes the clinician stupider in my opinion. Even the, I mean, not even the, it makes any clinician tend to think less in terms of what is good for this particular patient. Okay, I've achieved 135. Maybe we can push it a little bit harder. It's there are cardiovascular risks, but I can motivate the patient to go a little higher. And some of the patients, they're not going to be motivated, or is going to take a whole bunch of medications, and you're uncertain about whatever reason. You make a judgment, and take that approach.
Yeah, so if I can break down your questions a little bit. I knew this was coming to some extent. And one of my favorite quotes on guidelines is a quote from, he was a pilot in the UK during the Second World War, I think, Doug Bader. And the quote goes something like, rules are for the obedience of wise men. Rules are for the guidance of wise men and for the obedience of fools. And I think that applies to guidelines, right? You don't have to obey the guidelines. They are for your, just to show you a path. And that's my whole push against using them as performance measures is that, then you're being forced to obey the rules, and then you're labeling people as, okay, 138, you have hypertension, 129, you don't. on that specific angle, what I had hoped that AHA would have, but it did not, is this whole concept of repeated measures, right? Because if someone's blood pressure is 138 today, maybe they had a bad day, maybe it's white coat, maybe it's just that one extra visit. Hypertension Canada insists on either out of office by ambulatory blood pressure monitoring or home blood pressure monitoring, or 3 visits unless they have end organ damage.
I was unaware of that about the AHA. It's amazing that they would just say on the basis of a single blood pressure measurement.
No, but they do say you should do this and you should do that, but it's not like you must do that, right? We have a very tight, clear algorithm. Even in the UK, the NICE, they insist on ambulatory blood pressure monitoring or home. And in the UK, ambulatory is covered by the NHS, right? No one pays for, the taxpayer pays for it. I have to be careful what I say in this crowd, but it's reimbursed, or rather it's covered for the patients. They don't have to pay extra out of pocket. And if you do actually ambulatory blood pressure monitoring in those patients, your patient who has got 138, I suspect they'll be fine. Most of them will be fine. And that will avoid all this mislabeling diagnosis. So that's point one, that the AHA guidelines do stress that, but they don't make a firm commitment saying you must have out of office. The second one is about goal of thinking less. I would say it's the Doug Bader rule. Not everyone is like you. If I had a cardiologist, I would come to you. If I wanted a cardiologist, I would easily come to you or Anish or John or someone like that. But not every cardiologist is like that, right? Not every primary care practitioner is someone who has thought about all these things. Not everyone has time to look at the evidence for how to treat blood pressure. Look at the most primary care providers. You've got hypertension guidelines, you've got kidney disease guidelines, you've got atrial fibrillation guidelines, cholesterol guidelines. How many things how many actual core literature can you see and follow? It's very hard for all of them to do all that. So maybe guidelines have some rule to give some advice. I totally agree that they should not be followed brainlessly. And that labeling of someone as hypertension is also unfortunate, right? It's a risk factor. It's not really a disease for many of them. Dyslipidemia is not a disease. It's a risk factor. In our field, I'm slight segue on chronic kidney disease. There has been a lot of discussion about whether everyone with a GFR less than 60 has chronic kidney disease. And the president of ASN a few years ago, he actually made a statement that this is wrong, Jonathan Himmelfarb. And he wrote a paper and we had an FJC discussion on it. And there were 2 huge proponents, very smart people who came out saying, hey, this has made us realize that, it's a risk factor, especially in the elderly. There will be no one who is 80 years of age who does not have CKD. And I think that's not right.
I agree. I'm glad there's pushback.
Yeah. So all this labeling aspect, I don't like that. To identify it as a risk factor rather than say you have hypertension is separate. What about that goal? Your question about having a goal. To take an example with salt. So in Hypertension Canada, I'm in the Health Behaviors Committee. And we debated whether there should be a lower limit for salt. And if you actually look at the evidence for salt reduction, none of the trials said, let's go and achieve 2 grams of salt intake, which is what WHO says and which is what Hypertension Canada says. The AHA until a few years ago actually had 1.5 grams if you had hypertension. None of the trials even went for that the way, in blood pressure sprint went for 120. But it was based on observational data. And observational data in salt and food intake, it's notoriously misleading. But the rationale that came up, and which is why we did stick to 2, and I'm not saying everyone should accept and agree to that rationale, but the rationale was that people like to have a goal to strive for, right? If you don't give them a goal, then they are like, hey, okay, maybe this is low enough. Is this good enough? So to give something to strive for.
Is there any evidence for that, Swap?
No.
Is there any evidence that people like a goal to strive for?
No.
I'm going to push back because I have a lot of patients who don't, some of them may like it, but, they're obsessed about, some of them are obsessed about the numbers to begin with. And sometimes they want a number because they believe in their mind that this is, a true sign of a true demarcation between health and disease. So I don't know. I think the value of the goals are artificial. I mean, with all our propaganda, of course, now they're going to believe that they need to strive for a goal. But it's because in the first place we sort of have habituated them to think about cutoff numbers.
Exactly. And some people, I'm not disagreeing with you here. In fact, I would say that for some patients, it's the other way around, right? Especially with sodium. When you say, hey, 2 grams, they look at labels and they say, I'm never going to achieve 2 grams, and they give up. So it would be worse, right? If someone goes from 10 grams to 8 grams, I think that's useful. But if they are 10 grams and they say, hey, I'm not going to get to 2, so why bother? That's not a good thing, right? So it could be counterproductive. Those goals could be counterproductive. Just as with blood pressure, to go from 150 to 140 is useful, even if you don't get to 120.
Right.
So again, I don't disagree with you, but people say psychologically it's useful.
Though again, this is countering Michelle somewhat and asking you a question. The Accord trial in diabetics, and Sprint excluded diabetics, I believe, for that reason. Mm-hmm. There seems to be somewhat of a J curve, right? Lower may not be better in diabetics. So, how would we have? How would we have known that? I mean, was that a fluke? Do you believe that? And if there is some plausible explanation for that, then Michelle, how would we have known that without that study? And I mean, you need some type of lower number. So if lower is always better, then great. Maybe you don't need any number. But here, there's some evidence that's percolating that suggests that there's this J curve that exists. Right.
So I don't think. So frankly, I'm a little skeptical about Sprint. I mean, not skeptical that it's. I'm skeptical that it's representative of what can really be achieved. And that's true for blood pressure trials in general. The people who enroll in blood pressure trials are going to be very different from the average person that you see in your office, because management of blood pressure, there's such a behavioral aspect to it. So the clinical trials sort of pre-select people who are highly motivated, tend to be healthier to begin with, and that sort of thing. So is there a risk too low? Of having it below? I think that's true. I think that was known sort of even before Accord. It was known sort of epidemiologically, the J curve phenomenon. And I think there is reason to be cautious about it, specifically if you have a low diastolic blood pressure and so forth.
You would have thought, Michelle, that the diabetics, who are higher risk for cardiovascular disease and whatnot, that if anything, that would be, some subset that would especially benefit from low BP. So. It's an interesting
it is. So, but
almost wants to almost makes you a frequentist.
Right. But we're talking about what? I mean, trivial percentages, and you would never know. And plus, you might help some people by pushing it to some diabetics. There may be subsets of diabetics for whom it's harmful and other subsets for whom it's actually positive. You never know. At the end of the day, you can end up sort of questioning yourself. So I think for me, that's why I would stick to the general principle. In general, lower is better. There is epidemiological data, there is clinical trial data that it could potentially be harmful below a certain level. Okay, all this is fuzzy. And so you do what you can. And then if your patient dies, you actually will never know if it's because the blood pressure was too low or if it's because some other reason, right? You have no idea. So why even think about it too much?
So if I can jump in to talk about Accord, people say Accord was J curve. I don't know whether it was really J curve. So if you look at, I was just looking up so if you look at our HOPE-3 write-up for FJC, I made a table looking at the actual event rates. So yes, it was slightly higher, but if you look at, Michelle's absolutely right. In Accord, the total number of deaths were 150 versus 144. So that works out to 1.28 versus 1.19, which is really a trivial difference. It may just be chance. But if you see the composite cardiovascular endpoint, it was 1.87 versus 2.09. So it was lower in Accord. It was just not significant enough. And stroke was definitely lower, right? It was 0.32 versus 0.53 in Accord. So, and stroke is the one that's the strongly linked with hypertension. So, it again depends on how you want to spin it. Hypertension Canada went with Accord stroke and they said 130. In fact, the Australian guidelines say that if stroke is an outcome that your patients value, then you should aim for 120 in diabetics, which I think is I know shared decision making is a misused overused term, perhaps.
We've talked about that on this show.
That is about being careful, but maybe stroke is important for your patient, and then maybe it's important to be aggressive in the diabetic who values stroke, and that makes physiological sense, right? That would be true.
All right. So what's the chance? You sit on guideline committees, SWAP in Canada?
Yes, I do, and I'm speaking here in my personal capacity.
Right, I understand. But so you're not going to go back to your guideline committee and say, I've had this interesting conversation with these two guys from across the border, and we should, get rid of guidelines. I was going to say swap guidelines, but we should. This whole idea of guidelines, we should put it aside. That's not going to happen anytime soon. Is that right? Am I reading you correctly?
You're reading me correctly, but there's even when I was not part of the guideline groups, it was easy to criticize, saying, hey, these guys got it wrong. Sitting on some of these guideline groups, especially like Hypertension Canada, we have like about 80 people. Now I'm making it may seem like an advertise for Hypertension Canada, but there are 60, 80 people. There are nurses, there are dietitians, there are family doctors. It's not just cardiologists and nephrologists. And there's a lot of discussion about, if I say must, what are the implications of that? And maybe I should say should rather than must. So there is a lot of thought that goes into those guidelines. And I suspect something similar will happen with AHA. This is the first year, right, that the AHA came out with hypertension guidelines. They did not have any input from many other groups, including nephrology, as well as emergency medicine. I think the emergency part of the AHA guidelines are, could do with some improvement, hypertension crisis, and go to the emergency, those kind of things. So I suspect they'll improve with time with a few more iterations. Will they ever be perfect? I don't think we should look for guidelines to be perfect. You can always find something wrong.
Let me ask you a question here, actually, on that point. Do we have a sense of to what extent new guidelines truly impact what happens in the real world?
So for hypertension, again, for that you should you need an RCT of let's say
right.
Guidelines versus not. What has been done in our field is that they have looked at the Hypertension Canada has had the longest guideline process. It's been going on for I think roughly 20 years, and they have shown that the control of hypertension has improved in Canada. It's pretty good, and they spend a lot of effort talking outreach with family doctors, making sure they understand the guidelines. And so the guideline is only one aspect of it. There's a education program. They make a lot of resources available. So they show that hypertension control has improved, and our penetration of something like automated blood pressure is very high, which is at least due to some part from Hypertension Canada efforts. I think measurement of blood pressures we can all improve. There is no question about that. We measure blood pressures very poorly. Doctors, in our hypertension clinic, they do a fantastic job of measuring blood pressure, which I did not know until I started doing hypertension, right? So all of us think we know how to measure blood pressure, but we don't. So all those things I think have had an effect, but I can't swear and say that they have had an effect for sure.
Swap, Sprint was, I think 9,000 or so patients.
Yeah.
To show a difference. And I think the hazard ratio was like some
0.7 or so, like,
yeah, 0.6 to 0.9 was a confidence interval. Are the original studies, and Michelle is, both of you are hypertension experts, and Michelle, has written about the history of hypertension and stuff as well. So you can correct me if I'm wrong, but one of the first studies that looked at clinical effect was the VA co-op study.
Yeah.
There were two studies, one in 1967, one in 1970. And the initial study looked at a diastolic, men in the VA, veterans in the veterans who clearly hadn't done enough for their country. Now they had to be enrolled in these RCTs where they had diastolic pressures of 115 to 130, pretty high pressures, and they randomized them to BP meds or not, and it only took about 140 patients to show a pretty large difference. Now, the follow-up study looked at, I think it was in 1970, and was the diastolic blood pressure range was 90 to 115. And that also showed a difference. That was also 100 and some patients, right? Why, if we're requiring such a large number of such a large N now to show these benefits, do you think this is all within this law of diminishing returns? Meaning, back to Michelle's original point, how much are we really doing at these levels that that we're talking about in Sprint and Accord? And does it, I mean, should the number be, should all we be concerned about is that that the population's diastolic blood pressures are not over 115? Are we going to get that much more bang for the buck with everything that we're doing now?
You want to go, Michelle?
Yeah, clearly we're not going to get that much bang for the buck. I mean, we're talking about sort of trivial differences, and but it'll be fodder for endless arguments and editorials and that sort of thing. But to go back to your point, I mean, I want to say something about the first clinical trials. There were people who were convinced that treating hypertension was the right thing to do back in the 60s, and there was clear epidemiological evidence that lower is better. And you know who actually discovered that? It wasn't the academics, it wasn't the cardiologist, it was not the public health sector, it was the private sector. It was life insurance companies who discovered that in the 1930s. And what they did, they were interested in identifying baseline characteristics of enrollees in life insurance who might predict who would die and who would not die. And, in the 1910s and 20s, Korotkov had invented the method to measure the pressure non-invasively. There was no doctor who was measuring the blood pressure. They didn't care about it. They had no understanding of what it was. So life insurance companies in the US furnished private doctors with blood pressure cuffs, taught them how to measure the blood pressure, and collected the data. And lo and behold, they saw very clearly, and they published in all the top medical journals their data showing the relationship between, the higher the baseline blood pressure, the worse the mortality. And I don't think it needed that much clinical. Once antihypertensive medicines came about, I think a single clinician could get a sense that it was the right thing to do, because especially if you treated a lot of hypertensive patients, you could see the number of hypertensive urgencies decrease. It didn't take that much, a large number. You could, with a small number of N's, you could see that you were preventing hypertensive urgencies and so forth. So this idea that we needed an RCT is really driven by doctors wearing their scientist hat and wanting to show beyond reasonable doubt that we could. But what they do in that case is things that you talk about a lot, Anish, in your blogs, is that they expose a lot of people to harm, right? So you have the control group. A lot of them had strokes, who could have been treated. Now, you can argue it both ways. I don't want to stay on my soapbox here. But once you get beyond the point where a clinician can actually get a sense from his own experience that he's doing some good, then you're talking about trivialities, right? You're getting to the point where, okay, are we going to go to 140 to 130 or 135 and all that stuff? And you'll never know if you're doing any good or if it's worth the expenditure of brain cells.
This is why you need statisticians, Michelle.
Yeah, for sure.
I mean, how are you going to know if it's significant? 140 to 135. That is statistician.
Right.
Sorry.
That's my soapbox. Swap. What do you say?
So in some respects, it's true. We talked in the 60s and 70s whether blood pressure should be treated at all. And we didn't have many agents at that point, right? This is like we're talking about guanethidine and reserpine and those kind of drugs. And the later on trials when we got beta blockers and ACE inhibitors and stuff were more about, is the drug useful? Does using captopril improve mortality, or they all had with lisinopril, chlorthalidone, and so on. So it was more about which drug should you use. So no one could do a 120 trial in the 60s and 70s because there was no way to get down to 120. Now we do have many, many safe drugs, which makes it possible to go down to lower blood pressure. So that's one. And the second thing is, again, you can't do a trial of 120 if no one has shown that 160 is useful, right? So you have to show 160 first, then go down to 140, then go down to 130 or 120. So that's why I think this is a natural progression that has happened. I totally agree with both of you that this is sort of the diminishing returns, right? The effect is getting smaller and smaller at that level. So that's why you need a larger and larger sample size. But again, there was epidemiological data. There was observational studies showing that the lower you go, lower achieved blood pressure gives you better outcomes. But again, when you have JNC and all the other guidelines saying that, hey, it should be 140, someone has to show that 120 is better than 140. And the whole achieved blood pressure is a conundrum. Even with salt intake, it's a conundrum, right? It is achieved, and it can confound you, because people who achieve, my patient whose blood pressure is 110 versus my patient whose blood pressure is 180, they are different, because one of them has a good lifestyle and one of them takes his blood pressure pills properly. And maybe that's why his outcomes are good, nothing to do with the blood pressure being 110. So you can't really base, we needed to have a trial to see if 120 is really better than, is superior to 140. So the trial was necessary. Do I think there will be more trials of 110? I don't think so. The pushback to sprint has been so huge. No one, not no one, very few people. I'm in a minority who supports sprint on social media and elsewhere. And I think this is the right point, right? It shows you that we have probably achieved the limit of where we can go. It's almost balanced. You talked about the adverse events earlier, Michelle. Yes, so there is more AKI, there is more hypokalemia, hyponatremia, falls. So we are probably better off with lower blood pressure, but it's just it's so much on the fence that I don't think we'll be going lower anymore. The last thing is that in sprint they did choose a cohort that was at high risk. And also they excluded anyone who was at high risk of having adverse events, right? So that was again a different way of thinking than saying let's take all comers.
Mm-hmm. So given the strong link between blood pressure and outcomes, are you willing to forego outcome trials for blood pressure reduction?
Is this going down the renal denervation pathway?
I'm sorry. I'm looking at the clock, and it's my son's birthday, and I'm not sure that we can touch on renal denervation today. So we'll have to bring you back for that.
Yeah.
So maybe just some concluding comments about.
Sure. So it all depends on how strong a predictor you think blood pressure is, right? It's sort of like the lipid hypothesis. Do you believe that lower cholesterol is enough for hard outcomes, or do you want the drug to be proven? Especially for stroke and heart failure, I'm pretty confident about the blood pressure link with hard outcomes, that I'm comfortable with something that shows a blood pressure lowering to be enough. I'll leave it at that.
We have him on record. Surrogate endpoints are enough. Dr. Francis and the team is going to flog you now.
So he had the tutorial today, right?
No, that's interesting. Yeah, no, interesting you mentioned that. Dr. Francis, it seems like, can you parse? Sometimes it's hard to translate what Dr. Francis is saying, but that tutorial seems to suggest that he's...
His tutorial came in comment because of an FJC where, in fact, I had raised the question of should we have hard outcome studies for renal denervation? And he said that that hard outcome study will not happen. The true effect is somewhere between 4 to 7 millimeters. And if you look at the relative risk reduction in stroke and heart failure with that amount of blood pressure reduction, you will need 150,000 patients, which is $300 million.
Right.
So realistically, that study will not happen. So we should be happy with the data that we have.
Okay. On that note, I'm resigned to, having the guidelines continue to populate headlines, but that gives me something to talk about as a perennial contrarian. So, thanks very much, Swap, for joining us. Can you give us or give the audience where they can follow you on Twitter and the NFJC and anywhere else you'd like to people to know about? Any other place?
Perfect. Hey, thanks for having me. This was fun. I was not. I was daunted by coming on the show with the two of you, and you made it a pleasure. I can be followed on Twitter. Basically, I'm H Swapnil is my Twitter handle. If they're interested in NFJC, at NFJC, NEPHJC is our Twitter handle, and just go to nefjc.com where most of the data that I talked about is housed.
Great. And for the audience, we'll have this on the show notes as soon as we have the website and the podcast launched, which should be, I'm hoping, within, before the end of next week.
Wonderful.
Fantastic. I look forward to the podcast.
Yeah, Swap, thanks so much. Wonderful.
Thank you. Thanks, Anish. And thanks, Michelle, for having me.
Yeah. All right.
Thank you.
All righty. Bye-bye.